I was a practicing pediatrician for a while, and then I was a health services researcher. So I was doing lots of studies that was looking at variation in quality of care. I was looking at studies that said why we in Boston are 3 times more likely to hospitalize kids for their asthma, for example, than children who live in Rochester, New York, or New Haven, Connecticut. And I was publishing papers that said had a lot to do with quality of care, their connection with their primary care, getting the right medications. And actually it was a mentor of mine that cornered me one day, and he said, "Charlie, are you going to study this or are you going to do something about it?" And you know, that was the proverbial 2x4 upside the head that said, "Gee whiz, I better do something about it." And that's when I started to learn more about quality improvement, because I said, well, I know the healthcare system's not working, but how do you go about changing it? And I started studying from Dr. Berwick, and taking courses in quality improvement, how you make change. And then I was going along sort of learning about that, and then this project officer at the Packard Foundation, again, I wrote to her some small grant to help a project that one of my fellows and I were working on. And she also said to me something similar to that. She said, "Do you think you can change the world by publishing papers and seeing patients and teaching and try and change the world? Or do you want to spend all your time trying to change the world?" And I said, "Sounds like I should spend all my time changing the world." So that's sort of what moved me out of the academic world into the world of how do you actually go about changing the world. I was actually sitting around the real kitchen table with my wife one evening, and she said, "You know, our son has gotten miserable care for ADHD, and you know, you're a doctor, she is a lawyer." She said, "We still couldn't figure out the system. Can't you fix it so that other parents don't have to go through what we went through?" And I said, that sounds like a worthwhile activity. And that really led me to launch our whole ADHD work. I happened to be chairing the Committee on Quality Improvement, the American Academy of Pediatrics at that time, which was developing clinical practice guidelines, and I was able to encourage the Academy to develop a practice guideline for care of kids with ADHD. And at the same time, or shortly thereafter, say, okay, now that we know what to do, because the guideline says what to do, let's have our organization, NICHQ, focus on actually changing the world so that practice is aligned with improvement, with what we know how to do. So that literally, I mean, my purpose was so that other parents wouldn't have to go through what we went through, and that regardless of whose door, I mean, our experience in the mental health world was that the treatment you get depends on which door you walk into, not what the evidence says is the right thing to do. And I thought that's not actually how healthcare should be. Healthcare should be, if there's a right way to do it, whether you go to somebody you trained, you know, at this school or with this mentor or that mentor, you should still be getting what the evidence says should happen. So that really was the drive, both for founding the organization and then for sort of picking that initial focus on ADHD. Healthcare for children is extremely important because all children need healthcare. So, for example, for young children, that is 0 to 5, healthcare is really the universal point of access into not just health services, but services in general for children. So the quality of what they get there, including traditional medical services like immunizations or medications for acute infections, is very important. But it's also the vehicle for advice and guidance about parenting and child rearing. It's also a point of access into all kinds of social services that families need, identifying issues around maternal depression, identifying issues and addressing them around, for example, exposure to cigarette smoke. All of those services, we really don't have any other universal point of access for young families. And so that's why healthcare, for example, is particularly important for all children, period, full stop. In addition, there are some children, particularly children with chronic health conditions, where healthcare is critically important, where they're actually, their very lives and quality of life is really largely dependent on the quality of the medical services that these families get, as well as the integration of those services into other social and family support and education and other systems. So quality is critically important for all children. What aspects of quality varies depending on your relative health status, whether you're otherwise well and need social support or counseling and advice, which all families need, or whether you're, again, more dependent on what would be called traditional medical services. When I look at quality of care, there's some areas that have really shown some significant improvement. So when I look at, for example, hospital-based quality for kids, and I look particularly at areas of patient safety, which is one aspect, one narrow but very important aspect of quality, I think we've seen some real improvements in quality of care. So I think we've seen some real reductions in bloodstream infections in children, particularly those cared for in Children's Hospital. That's really made a difference. So I've been pleased about those areas. I think in terms of quality of care in the ambulatory arena, which is where NICHQ's focused its work, there have definitely been what we'd call bright spots. I mean, for example, the Cystic Fibrosis Foundation has really led dramatic improvements that have been well described about using national registry systems, and we've seen the replication of that for other specific chronic conditions. We're seeing that inflammatory bowel disease, and NICHQ's work is really trying to focus and apply that to the care of people with sickle cell disease. In some areas, like asthma, we know what to do, and we're still not applying it as consistently as we might. In other areas, particularly many of the chronic conditions that affect children, as well as some of the sort of complex behavioral issues like childhood obesity and, like, for example, some of the mental health issues and substance abuse issues that older children have. We still don't have a great handle on what we could be doing and should be doing, and I think we need to get better information about how to do it. One of the things I've been excited about that's happened in the field of quality over the last 5 or 10 years has been a bringing together. We used to think you need to do the research first, and then you can use quality to improve performance once you actually know what to do. I think we've started to see that the fields are not as different as we thought they were, and you can actually learn while you're doing quality improvement and apply some of those same methods. So we're seeing that in a few areas, and it gives me hope, optimism for where we need to be going. What can this country do to do a better job for children's health care? Health insurance is still critically important for all children, and not just children, but their families. So they need to get access. Second, we desperately need better measurement systems so that we can actually monitor and improve quality of care in an ongoing way that's not incredibly burdensome for the providers. Another thing we need to do is align the financial incentives so that it's in the interest of the providers in the healthcare delivery system to provide high quality care. Current incentive systems, to the extent they look at health, are working in very short term. That is, if you improve care and quality, can you reduce costs within the next 3 years? That doesn't work for children. We need to come up with different financing mechanisms that allow a much longer view return on investment. Fourth, I think we need to set up an infrastructure, a national infrastructure, to support quality and quality improvement at the community level. So NICHQ has been doing a great job with our work at a national level and supporting national programs. But what we really need to do is enable at the community level and at the state level technical support to enable providers in those communities to be both developing their own skills and improvement to getting the help that they need. I think if we can do all of those things, we'll be making a great deal of progress. There are 3 relevant parts of Obamacare, or the Affordable Care Act, that are very relevant for child health. The one everyone knows about and pays attention to is health insurance. So it's providing access to health insurance. Critically important, highly controversial. Let's leave it aside. Very important. The second element is the one Dr. Berwick talked about, which was the reform of the healthcare delivery system. And the Affordable Care Act has a number of things that promise to reform and restructure the healthcare delivery system. The most prominent of which is called accountable care organizations, where delivery organizations which includes hospitals and primary care systems, are not only responsible for delivering care, but also basically become the insurance agent. They're responsible for costs. So that then starts to transfer the accountability for performance for health to these organizations that actually have the ability to deliver it. That's very important, and there are a variety of other components that really work on restructuring and refocusing the healthcare delivery system, moving more to health. I think that's very important. The public doesn't understand it. It's very hard to explain, but is, I think, as or more important than the insurance aspect. The third part, which is really completely, I think, unknown and unappreciated, has been a very substantial investment, or an attempted investment through the Affordable Care Act in public health systems. So, for example, it created a Prevention and Public Health Trust Fund, which is largely what supported our work on childhood obesity. It's largely what is supporting or has supported our work on breastfeeding. So those other kinds of investments, which says that we really need to not only have a healthcare delivery system, but a public health system that's integrated with the delivery system in order to improve outcomes, is something that is part of the Affordable Care Act. I think the Ebola epidemic, or the outbreak, the risk of the Ebola outbreak in the United States, is bringing to public awareness the need for having both a strong public health infrastructure connected to a clinical delivery system. That same kind of integration between public health, community awareness, population health, and traditional healthcare delivery is something that is a minor theme within the Affordable Care Act. And I think I'd like to see that elevated substantially. And again, I think that's particularly important for children because, again, what keeps children healthy is at that interface between public health, again, as reflected in our breastfeeding work, and clinical care delivery. And that's been the direction that NICHQ's been moving in over the last 5 or 10 years. We know how to bring people together, get them to work together, and give them a method and tool for them to make changes. Again, for us, it's kind of like breathing, so we don't realize how special it is. But when I go and work with other organizations that don't have this or are just starting this process, and I look at how awkward they are in trying to make things happen, I think, you know, we do this like breathing or walking. We don't even think about how do you pull experts together and synthesize what the best practices are. How do you develop a measurement set that allows you not to judge at the end, but to track your progress along the way? How do you bring teams together and help them make incremental changes that over time will aggregate into large-scale improvements? That's what we do. We know how to do that. We also like bringing groups together that have similar challenges. Because we think that peers can teach each other a lot more than experts who learn in academia or in government about what to do and try to foist those approaches on them. We think actually others who've walked in the same shoes and have solved some of the same issues are much more likely to be able to offer good suggestions. It's been very powerful when we get that to work. Again, as it's worked in our breastfeeding work, it really seems to be making progress in our infant mortality project. It's worked in our asthma work and our ADHD and our obesity efforts. We really try to be a coach at the side. You know, we're not even a teacher. We're certainly not a director. We're different than a consultant. We really try to be a coach at their side, to give them guidance, to give them ideas. We recognize that their contexts, they know their environment far better than we do, so it's foolish for us to come in and say, this is how you do things. We can say, this is how others have done it. These are ideas that seem to have worked, and how can we help you test these ideas in your environment and see if it works? Lots of academic papers have highlighted and decried gaps in quality and poor outcomes for different populations of children. What NICHQ has always done is not only elevated those gaps and said these are areas that we need to pay attention to, well, we provide hope in saying we have a strategy, a method, and tools that can help initially healthcare delivery system and increasingly communities and public health address some of these long-standing gaps. We have an extensive network of we call faculty, which are our experts that we draw on, because again, we can't have content expertise in every area we work in. We now have networks with public health leaders across the country. We've worked with hospitals, we work with primary care practices, we work with professional associations. We'll really work with any group that shares our mission and is willing to work together with us to address the health problems that we're focused on. The fundamental idea that NICHQ brings to the world in our work in improving children's health quality is that in order to improve, you need two different kinds of knowledge and two different kinds of skills. So one set of knowledge and skills is what healthcare professionals and most professionals are trained in their schools. In addition to that knowledge, you need improvement knowledge. You need the knowledge of how do you actually change systems, and that if you want to change performance, whether it's your immunization rates or your infection rates or the frequency of child abuse in a community, you need to think of what are the components of that system and understand how those different components relate to each other, and realize that if you change just one element of that, you're not likely to change overall performance. Another aspect of improvement science is the concept of measurement and understanding that there's variation in every process, and figuring out what kind of variation is built into that process and what kind of variation is outside the normal process. So if it's outside the normal, that sounds very arcane and very complicated, but it's important to know, for example, if things go wrong on a particular day, is that something that's just inherent to the normal variability, or was there something special, like somebody didn't show up that day to work, and could that have been predicted or not? There's another element of improvement science, which is how do you go about learning? Do you learn from small incremental observations and reflections? A common example of that is when you learn how to ride your bicycle, or when you learn how to golf. Do you study a textbook and then learn from the textbook and then automatically go out and do it right the first time? Or do you go out and try and notice if you're riding a bicycle that you fall over one way and you fall over another way and you realize you have to balance? Or if you're trying to learn how to golf, you hold your club one way and you hold your club another way, and eventually you figure it out by trial and error, or trial and learning. So those are some of the elements of improvement science that we bring to bear. We also study a lot the issue of how do you bring things to scale. How do you go from trying things and learning things in a single clinic or a single doctor's office and spread that to a whole organization? How do you spread it from an organization to a whole state? How do you spread to a whole country? And so we spent a lot of time thinking about this concept of spread and scale, and we include that, for example, in our elements of what we call improvement science. What we do at the start of every project that we do is we get the organizations to work together to come up with a shared collaborative aim. It's actually amazing when you talk to people about projects that you're doing and you say, now, what are you trying to accomplish? Many organizations say, I'm not really sure. So we really focus at the start in getting a lot of clarity about what it is that you're trying to accomplish, and then to see if there's a measure that you can come up with that allow you to identify whether you're making progress towards that aim. Even in our initial work in improving care and outcomes for children with asthma, we realized that children spend their time in a variety of settings. So clinicians might see them in their office, but most care happens in the home. So that's something where you need to understand how does the parent make things happen at home. And then as children get older, whether it's in preschool or in school, that's another sector. That's another place where children live. So how do you start working with the educational system and get them to appropriately manage a child with asthma? How do you work with the coaches so that kids with asthma can function well and participate in sports? So that was sort of our first foray where we realized that we had to start working across sectors. When we got into our next major topic of attention deficit hyperactivity disorder, the diagnosis of ADHD can't be made without getting input from two different sectors. You have to get input both from the parents and from either school or after school or another context, because you don't want to make it solely dependent on how a child functions in a particular context. So again, that was the idea where NICHQ became more and more comfortable dealing across sectors. Once we then started getting into addressing the topic of childhood obesity, we realized, again, we started our work with how do you manage both prevent and treat obesity within the clinical office practice. Even that work, we realized you had to have linkages to after-school programs, to Boys and Girls Club, to school, to what food kids get in schools. But then we realized, well, how do we actually start changing those community contexts? And that's when we really realized we had to start bringing the sectors together to develop common plans and common aims and start using measurement systems across sectors. That was challenging because many of the other sectors use a different language than healthcare uses. They're less familiar or differently familiar with measurement. Schools may be used to measurement for judgment. Public health systems are used to measuring things every 2 or 3 years and looking at data that's very old. And we needed real-time data. So it took a lot of cross-sectoral learning, cross-disciplinary learning, and I think that's a continuous journey that I think we've gotten better and better at, but we still, I think everyone who works in that space has a long way to go. We have tremendous people here. We have a strong record of accomplishment and a set of very strong trusted relationships across the entire field. So it feels like it's a really appropriate time for the reins to be passed on. I certainly hope that we will continue many of the themes which we have developed over these past several years, bringing hope, bringing methods of collaboration, bringing methods of quality improvement, both into the areas of the management, the sort of healthcare, traditional areas of healthcare, as well as expanding into some of the areas of public health and child well-being. We love to see more people coming to us across a variety of things. So we would love to have, for example, a much more established network of practices and systems and organizations that we could work with on an ongoing basis. We'd love to have communities come to us where we could work with them and say, how can we make this community the best place for a child to grow up, and to have the kind of partnership with them, with their healthcare delivery systems, their public health, their other community organizations, to set up the kind of measurement systems and improvement systems that would help them really meet child and family needs. I hope that the new leadership will also bring new methods and tools. So it's not that I'm that old or senior, but certainly there are methods of collaboration, online collaboration, that I think are exciting, and I'd like to see more of that brought to bear. I think the whole field of sort of social entrepreneurship and how to bring in some of the new ideas, new ways of funding organizations, that the younger social entrepreneurs, venture philanthropy, I'd like to see some of that happen, some of the concept of social impact bonds, again, aligning sort of private investment with improved child health outcomes, I think would be a tremendously exciting thing for us to be moving into.